I have two talks today, and the first one will be on thromboembolic complications of bladder cancer, and this is invasive bladder cancer. And I'd like to take you through three trajectories of the disease. One is in the post or peri-radical cystectomy time. The other one, it's a different patient population, which I think deserves a specific attention, and those are the patients who receives neoadjuvant cisplatin-based chemotherapy. And finally, a few words about metastatic bladder cancer. So there is an accumulating data to suggest that cancer confers an increased risk for development of thromboembolic disease. However, the risks vary with different types of cancer. This is data from 11 different tumor sites or tumor tissues that were treated surgically. This is the NSKIP, the National Surgical Quality Improvement Program of the American College of Surgeons. And this looks at the 30 days incidence of DVT in patients that were operated for these types of cancers. And you can see that bladder cancer confers a significant risk of DVT, only second to esophagectomy. When you actually look at PE, bladder cancer superpasses esophagectomy is the number one cause of, or number one in terms of development of PE. And if you look at all VTE or venous thromboembolic events, it's again very high and second only to esophageal cancer. What do we know about radical cystectomy? So Teresa Kupi from Oregon looked at the same data and looked at 1,300 patients that underwent radical cystectomy. And there are very few interesting observations in this retrospective observation trial. So first of all, there were a 6% overall incidence of clinical venous thromboembolic events, and the median time for that was 14 days. So the risk of actually developing a VTE exceeds beyond discharge from hospital after radical cystectomy. In fact, half of the patients were diagnosed with VTE after discharge. And the 30-day mortality related to VTE is enormous. It's about 6%. Within the limitations of her study, she could predict that age and operative time in sepsis were associated with VTE. So more than 50% of the patients develop VTE post-discharge from radical cystectomy. There may be a role for extended VTE prophylaxis. This is just another graphic presentation of what she showed. And indeed, there was the Sanofi trial, the Enoxacan 2 trial, that looked at extended versus non-extended prophylaxis with low molecular weight heparin. This was not a urological specific study. About 10% of the procedures there were urological, but it was a double-blind, randomized, multi-center trial in patients undergoing planned curative open surgery for abdominal pelvic cancer. They received either enoxaparin for up to 10 days to discharge, and then randomized to either receive placebo or 21 days of enoxaparin. The endpoint here is a little bit disappointing, but that was early days. It's radiologically detected VTE or DVT, and this is actually not the hard endpoint that we would like to see, which is actually a clinical event. You can see about 10% of the patients underwent genitourinary cancer operations, but strikingly, there was a statistically significant difference between extended prophylaxis and regular prophylaxis in terms of development of VTE. And this did not come on the expense of having, the expense of having a significant risk of bleeding. What happens with radical cystectomy? Well, we don't know. There are no randomized prospective trial for radical cystectomy. But there is this interesting, very recent paper from the University of Chicago group, Gary Steinberg, where they actually retrospectively looked at their practice in between the January of 2011 and May of 2014, where they switched between standard prophylaxis around the procedure to an extended prophylaxis of 28 days. And very interestingly, one can see the following. So they had about 400 patients, 234 received standard inpatient prophylaxis, 170 or so received extended prophylaxis. And you can see, or they could see, that the overall VTE rate decreased significantly from 12% to 5% on the extended regimen. And the main benefit was post-discharge, okay? Those are patients that we are not following. They went home. There was a 46% of VTE that occurred after discharge. Again, about half of the cases occurred after discharge. And within the non-randomized methodology, they could use a multivariate analysis and could show that extended prophylaxis was independently associated with decreased risk of VTE. And they didn't show any significant increase in bleeding in their trial. And the most important thing about this study is that actually the endpoints here were symptomatic VTE. So it's not radiologically detected. It's a very hard endpoint, symptomatic VTE. So to summarize here, in patients with bladder cancer who undergo radical cystectomy, VTE occurs with a significant frequency. Again, if you compare it to other disease sites, it's only secondary to esophagectomy, associated with morbidity, cost, and mortality. And potentially, there is a potential for extended prophylaxis given the fact that at least half or more of our patients develop this sometimes lethal venous thromboembolic events post-discharge. But I think there is another patient population that deserves specific attention. And we actually looked at that a couple of years ago. We looked at patients that received neoadjuvant cisplatin-based chemotherapy because we observed very, very strange things with these patients. We observed patients that are developing arterial thrombosis. Some needed even embolectomy. Very weird things, and we thought we will compare it to patients that undergo upfront radical cystectomy, and this was within our institution. The main findings were that we showed that there was almost a four-fold difference between patients that received neoadjuvant chemotherapy and then cystectomy compared to patients that are undergoing radical cystectomy. So essentially 1 in 5 patients receiving neoadjuvant chemotherapy developed VTE compared to about 6% that went to upfront cystectomy. And interestingly enough, there was a signal that this is an independent predictor for progression and cancer-specific survival. So then we went and tried to confirm that retrospectively on a multi-institutional data, institutions from Canada, and Peter Black is a co-author on that, the United States and Europe. And the idea here was to potentially define a rationale for a randomized prevention placebo-controlled trial. So we wanted to define the incidence of thromboembolic events in patients with urothelial carcinoma that undergo neoadjuvant chemotherapy, to characterize these thromboembolic events, the detection methods in a large multi-center data set. We called thromboembolic events, we defined them as radiologically confirmed deep vein thrombosis, or PE, arterial venous or port site thrombosis, or any patient that started anticoagulant medications during the neoadjuvant chemotherapy period. So these are the different institutions. We had, in final analysis, around 830 patients. We did characterize them by the Corona score. Now, Corona score is a score that was developed for patients that are undergoing chemotherapy, and one can give a numeric risk to develop a thromboembolic event. This relates on a very simple parameters such as cancer site, hematological measurements such as the pre-chemotherapy platelet count, hemoglobin, and leukocyte count, and the BMI. Essentially, there were no difference actually between the patients who developed thromboembolic events, and those who did not in all of these parameters. Gemcitabine and cisplatin and MVAC were, as can be predicted, the most common chemotherapy regimens. And you can see here the overall, there was about 15% chance of a patient on neoadjuvant chemotherapy to develop a thromboembolic event. Now, I will relate to the variation between the institution because we believe we know the reason for that. And then you can capture data related to the timing of a VTE. So this is development of a VTE or thromboembolic events, if you will, pre-operatively. So this is just at the time of the neoadjuvant chemotherapy. And you can see that happens in about 7% of the patients. that undergo the neoadjuvant chemotherapy. Now, why is that so varying? Okay, why, for example, in our center, Jovitsky Cancer Center, we had such an increased risk compared, for example, to Turku in Finland or McGill. And we believe that that relates to the practice of post-neoadjuvant chemotherapy imaging. Some centers do not do a CT chest as a routine, they do a CT abdomen and pelvis. And what can happen is that that happened to us, can identify what we call incidental PE. Now, incidental PE has a very sexy name. Incidental PE, nothing would happen. But essentially, if you look at the thromboembolic literature, this carries the same risk and the same prognosis as symptomatic VTEs. So it's very important to identify them. And it did happen to me that I scheduled patient to radical cystectomy post the neoadjuvant chemotherapy, and the radiology calls me and says, "Did you realize that he has a PE?" So I don't know what the clinical practice of each one of you, but I would recommend for you to do a CT chest as part of your post-chemotherapy, and perhaps you will find more and more of those. This relates to the development of TE post-op, and this is early, about up to 30 days, and it's about 2.6% in this patient population. This is less variable between the institutions. And most importantly, in here we capture data of over 30 days. And still, those patients are at risk to develop thromboembolic events after 30 days, a period that nobody imagined or would like to give an extended prophylaxis. And I urge you to think of that bladder cancer is actually a very thrombogenic disease. And this is another way to show that. So if we censor that at 3 months, but you can see that there is significant risk of developing thromboembolic events up to 3 months post-surgery. What are the type of thromboembolic events? So most of them were either a PE or a DVT or both. There was port-sized thrombosis. We didn't have any stroke, arterial emboli. I presented this data at the AUA a year ago, and people came to me and said, "Well, funny, you know, I had a necrotic bowel." People comes with weird stories, and it is indeed a very thrombogenic situation. How do we detect them? So we detect them mainly clinically in 2/3 and incidentally in 32%. And again, I think that relates to the practice of how you image your patients post-neoadjuvant chemotherapy. And there was some association to survival if you had any thromboembolic events. So perhaps having a thromboembolic event or having thrombogenicity is actually a biomarker for worse disease, and there is a lot to say about that, but I won't due to the time issues. So in conclusion, I think that TE are very common in bladder cancer patients who undergo neoadjuvant chemotherapy followed by radical cystectomy. Majority occurs actually before the radical cystectomy, so be careful about that. These are TEs, an independent predictor of progression-free survival after adjusting for age, corona score, pathological stage, and so forth. And I think this merits now a trial that we are heavily involved in planning for a prophylactic or a prospective randomized trial for prophylaxis. Final words, just to shortcut and potentially bring us back to time. This is about the risk for developing thromboembolic event in patients with metastatic bladder cancer. This is well established. I thought just to bring this paper because I think it's interesting. This paper actually gives some potential predictors for thromboembolic events in these patients. Interestingly, if one has non-urothelial histology, the risks are increased. The same if one has moderate to severe renal dysfunction, and interestingly enough, cardiovascular disease, and there is a lot of literature to connect between actually arterial thrombosis and venous thromboembolism disease. So I'll end up here.